Hi everyone, my name is Vic. I'm an ENT surgeon working for the NHS. And in this video, I'm going to explain something about sinus infections. And I'll try and explain it. I'll start off with the very basics. So most people will be okay with that. And then I'll go into more depth, more detail later on because it, it's really detailed. And there's a lot of information out there and it's really complicated. And we don't really know an awful lot about sinus disease. So I'm going to try and explain it in what we know now and how treatments are different for different people. But I'll start off with the very basics, as I said. Sinus infections, okay, the sinuses are just holes inside the bones of your face. So, for example, the cheekbones here, they're not solid bone because it'd be so heavy. If all this was all solid bone, it'd be quite heavy for you to lift your head up. So there are big open spaces within the bones of our face. There's big ones here called the maxillary sinuses. There's big ones here in between the eyeballs, which we call the ethmoid sinuses. And there's big ones here called the frontal sinuses. There is another one right at the back of your nose in the sort of area right at the back, and that's called the sphenoid sinus. That's an interesting sinus because when you get pain there, you get pain right at the top of your head there. So if you like going, what is this pain? I've got a blocked nose and I've got something here. That's the pain you get. There are situations, however, when these little holes between your nose and your sinuses can get blocked. That's normally not such a bad thing. You just blow your nose and that bit of mucus comes out and everything's fine. But sometimes, particularly in people with a very inflamed nose, cold or flu, or maybe sometimes rhinitis, which means you've got hay fever and things like that can interfere with the functioning of your nose. It can close up that hole and mean that fluid that's made in the sinuses, when I say fluid, mucus, sort of snot and things like that, that's made in the sinuses. They're not just bone, they're lined with the same sort of lining that your nose is lined with. So it constantly makes mucus, makes bogey and things like that. And if it's blocked, that hole between your nose and your sinus, it fills up this sinus all the way up like this. And initially it feels a bit heavy and it feels a bit odd until it gets right to the top. And then it's completely blocked off and it's just full of fluid or mucus or something like that. That in itself doesn't cause an awful lot of problems. But if you leave fluid anywhere in the body for long enough, in your gallbladder, in your actual bladder, in your ear when you've got when kids have glue ear and things like that, if you leave fluid anywhere stagnant in the body for a long time, it will eventually get infected. And when you get an infection, a bit more science, sorry. When you get an infection, these bacteria are breaking up and eating things. And that what that does is it makes the fluid in your sinus more concentrated. So much so that it starts recruiting, pulls in fluid from the outside. So that sinus can't now hold the extra fluid that's filling up in the sinus. So it starts hurting because it's pushing against the walls of the sinus, desperate for it to come out. And then you get this horrible sort of pain that can happen here in the maxillary sinus, ethmoid sinus between your eyeballs like this, or in this area here, or as I said before, the pain right at the top, which is sphenoid sinus. And when you get this pain, it really hurts. Here you'd get pain that almost pushes down sometimes on your teeth. Some people say, I've got toothache. It's not toothache, it's your sinus pushing down on the roots of the teeth. Obviously, it could be toothache, but that's one of the causes of an unusual sort of toothache. It could go, if it's around here near your eyes, it can go into your eye, you can get a big red eye. If it goes up here, it could come out and come at the front of your forehead like this. It's called a Pott's puffy tumor. It's not a tumor. It's just pus that's gone through the front of your skull, and it's terrifying. So there are all sorts of things that this can cause it, but it's the pain where it stretches and pushes against the walls of its containing cavity. That's the pain that you're experiencing. Plus, you've got the infection, you feel awful, you feel run down. Typically, your nose is blocked, sense of smell tends to go, and all these things seem to occur. Now, these are generally acute infections, like a cold or a flu or something like that. You go and see your doctor, they'll give you the right treatment, which is typically a decongestant nasal spray. So I've been banging on about not using decongestants throughout my channel, but this is a good time to use decongestants. Decongestants are things like Otrivine or Sudafed sinus spray, things like that. If you spray this up your nose, it's really good at shrinking down the inflammation in your nose. You may have inflammation around those little holes between your nose and your sinus. You're trying to unblock that hole so all this fluid can just pour out rather than going into your eye or going into your teeth or going into your brain and things like that. You want all this fluid to come out, and you go, oh, once all the pressure comes off, the pain goes, and you feel so much better. So that's the first step. The next step is to try and clean out these sinuses because although some of the pressure may come out, it's still half full with gunk and infected material. And if it stays there, it sort of smells and it could fill up again and cause more swelling and infection around that little hole and block it up again. So what you're trying to do is get a of water and just clean out all those sinuses. So typically in the UK, we use something called NeilMed sinus rinse, and there are other things as well. It's just a squeezy bottle, really. And you fill this up with sterile water. Normally, we tell people to boil it and let it cool down to make sure it's sort of vaguely sterile. And you use one of these sachets, which has got salt and sodium bicarbonate and things like that in it to make it salty. You don't want this to be just water because, in fact, it'll make your nose slightly more blocked. You want it quite salty. And that's what this is for. In fact, if you put two of these, that might be quite useful. It does sting a little bit if you put two of these or three of these in one of these bottles, but it does shrink down the lining a little bit more. It becomes hypertonic. If you know your physiology, if you've got lots of concentration in this water going around your nose, and it's very, very thick, salty type water, it draws out the water from the nasal lining and therefore shrinks your nasal lining down. So that's the idea of that. It does sting though, it makes your eyes water if you do too many of these. So you fill this up, there's a little water line measure here. You fill this up, you put it up your nose, and then you squeeze gently. Don't go so hard it ends up in your ears and things like that will hurt. You want to try and flush out the sinuses. Now, sometimes it goes up your nose and just comes straight out of your mouth, and that's fine. At the start, it'll feel like you're waterboarding yourself or something like that, and it's awful. But you're trying to clear out the mucus as much as you possibly can and get into those sinuses. And by doing that, you're eventually, when you do get into sinus, all this pus will come pouring out and the pain will go. You'll still feel awful because you still have a infection, you still have a cold or flu, whatever, but at least the pain has gone. At least the chance of it going into your teeth, into your eye, into your brain, all that has gone. That's the idea of these things, to try and flush out all that infected tissue inside your sinuses. Sometimes you need to do this several times in the day. In fact, some people will just do it every half an hour, every hour, just to keep going until they clear out that mucus from inside their sinuses. It's a bit of a pain, but this is useful for sinus. I mean, it's got it on the packaging, sinus rinse. That's the idea of it. It means to go around the sinuses. Some people, when they've actually gone into their sinuses, they feel like, actually, I think it's worked. And then later on in the day, when they're perhaps lying on the sofa or they're bending down to pick up something, suddenly all this fluid comes out of their nose. That's not a bad thing. It means that this has gone into your sinuses and sat there. And then when you turned your head in a particular way, all the fluid has come out. It means it's got into your sinuses. It's a good thing. Um, but keep cleaning it out and it will come out. It's not a dangerous thing. And so the next thing we generally do, if it gets really bad, the infection is really spreading and people are getting worried that maybe it might spread to other parts of your face or make you feel really, really unwell, end up with sort of septicemia, things like that. We tend to give antibiotics. And we give normal antibiotics typically, something like augmentin, comoxiclav, or something like that. And that generally, that little trio of things seems to help. First, you need to unblock that hole to get all this fluid to come out. You need to flush out the fluid. And then you also need to give antibiotics in some cases. Now, the reason why just one of these doesn't always work, because for example, if I gave you a flush to clean out your nose, but your nose is completely blocked because all the swelling, well, it's not going to actually get to that hole to clean out the mucus that's blocking it. So you do need a decongestant to get to open up the hole so that the flush can get in and clean out your sinuses. If you just use a decongestant, and remember, you can only use a decongestant, the Otrivine and Sudafed spray for about 4 or 5 days max, really. But if you just use a decongestant, then you're not really cleaning out that muck inside there. So you do need to use the sinus rinse as well. Some people, if they haven't caught it quickly enough, there's still infected tissue within their sinuses that's making this pus. And even though you clean it loads and loads and loads, it's still developing, it's still causing a problem. So you need the antibiotics as well. But you need all three in some cases to clean out this sinus infection. And hopefully you won't have this problem again. There are situations where actually the sinus infection has been going on for a bit too long, and we as doctors are worried, this is going to last a little bit longer than we expected, and we don't want them to be taking the Sudafed and Otrivine spray for more than sort of 4 or 5 days. So maybe we'll start you on a steroid spray to just calm down the sinuses, calm down the nasal mucosa to stop it from blocking your breathing. So we start giving you some fluticasone propionate or something like that, some good quality steroid spray that doesn't give you all the side effects of steroids. So keep using that for probably 6 weeks or so, just to bring down the swelling inside your nose to stop it from happening again immediately. There are some people out there who keep getting these acute infections. They have no problems in between, but for some reason, every time they get a cold, every time they have a slight issue, they seem to get a sinusitis infection, pain, and all sorts of stuff. That I suspect maybe because they've got a blocked nose, or maybe polyps, or maybe their nose is slightly twisted to one side and blocking that sinus on that side. There are lots of reasons for that. And what we would do is say, well, there's a reason, for whatever reason, that your nose is getting blocked. And it might be that we just need to straighten out the septum or open up the hole a little bit bigger so it doesn't keep getting blocked, or give you those steroid sprays as long as it's the good quality ones that don't cause you long-term side effects. So use the low bioavailability nasal sprays, which I talk about in my other parts of this channel. And that's to prevent that hole from closing down, causing these acute infections and needing antibiotics and things like that. So that's acute recurrent sinusitis. Now, there is another group which becomes a lot more complicated. And if this is enough information for you right now, you can stop this video. But this next bit is really complicated and it's changed an awful lot, particularly since 2020 when the EPOS guidelines came out. So I'm going to try and explain it bit by bit. And that's when the sinusitis infection that you've had becomes chronic. When we say chronic, we mean typically over 12 weeks. But you get a feel for something that's becoming chronic when it's going on for a few weeks and it doesn't seem to be abating. So you just think, this looks like it's turning chronic. And what that means is it becomes a very different disease. And we used to say, oh, well, just give the same stuff. Give steroid nasal sprays. So you can't use decongestants long term. So steroid is supposed to open up the hole, flush out your sinuses, and give steroids. We found that somehow macrolides, things like clarithromycin or erythromycin, those sorts of things that end with icin, azithromycin, all these antibiotics, macrolide type antibiotics, seem to help sinus infections. And you can use a little dose all the time, long term. And that works really well, we thought. But we started noticing that some people did really well with antibiotics, and some people did really badly. And some people did really well with steroids, and some people didn't do so well. Some people we thought, surgery doesn't seem to do anything. All this stuff doesn't seem to do anything. What's going on here? Maybe we need a different class of drug altogether. And over the years, particularly in the last sort of 10 years or so, we've been trying to subclassify all of this. This is where the complexity comes in with chronic sinusitis. Now, I'm not going to go into those people with big polyps. Um, Polyps, I'll talk about in another video because it gets really complicated. But polyps, you need steroids for, basically. And the steroids will shrink those polyps down, and you need to try and stop them from coming back. And I'll talk about that in another video. I'm just talking in this video about chronic sinusitis without polyps. And actually, there are three different classes now. Now, these three different classes, and there's a lot more classes in this, but I'm trying to simplify it for everyone here. These three different classes, 1, 2, and 3, endotypes they're called, they are they're important to know because it slightly changes the way we treat patients. So what I'm going to do is go through these different endotypes one by one and sort of explain them, and hopefully I'll try not to confuse everyone about it. So type 1 is quite common, particularly in the Western world. And this is what we call a sort of a classic sort of picture of people with sinusitis. They tend to be sort of middle-aged, not really asthmatic or eczema, hay fever, those sorts of people, but they have the proper signs of pain, thick mucus coming out of their nose and out of their face, green, brown, and sometimes blood coming out of their nose. Lots of pain, typically here in the frontal sinus, They also get quite a lot of blocked nose, but they don't seem to get as much loss of sense of smell, which is a different endotype, weirdly. So the classical picture I sort of told you about in the acute phases, but it sort of carries on in the chronic phases. When you look inside the nose, it looks quite red and angry. And when you take blood tests, you don't see the raised IgE in the eosinophils. This is mostly neutrophilic. Now, I'm talking about IgE in the eosinophils because it's useful in type 2. But for type 1, these levels are normal. The immune system is mostly about the neutrophils rather than the eosinophils. And all that means is that it helps us decide what sort of treatment to give these people. Now, generally, we give steroids to these people. We give the nasal sprays and we give the macrolides, the erythromycin. I tend to give clarithromycin for some reason, unless you've got heart problems. And giving these antibiotics, particularly, is really, really useful for this type 1 type of person. But the steroids seem not to be quite as useful as some of the other types. So, although the steroids are useful and we sort of give them to everyone, we don't find them as beneficial for type 1 people. In fact, we say, okay, use the sprays, but also put some steroid in your mixture of water in this. Now, it's important to sort of vaguely understand this, and I'll talk about this in type 2 because it's much more important in type 2. But macrolides is what type 1's all about. Using these macrolides, these antibiotics, which weirdly have an interesting effect on the nose. They even shrink down polyps. It's an interesting, it seems to work on neutrophils. That's why I talk about neutrophils. So macrolides, these antibiotics that um, seem to shrink down polyps, open up your nose, seem to deal with the infections in your nose. They work very well in type 1 patients. And generally, you go on to surgery, which is just basically opening up that hole between your nose and your sinus, making that hole slightly bigger. I tend to make it less than 8 millimeters, which I'll talk about in another video. But making that tiny hole into a small hole rather than a huge hole is what seems to work best because really what you're trying to do is allow this irrigation now with steroid in and using your steroid spray to get round your sinuses. And sometimes it gets blocked easily, but you want this to get into those sinuses. So making that hole bigger. The operations don't fix the infection at all. You can't cut out an infection typically. What you're trying to do is make it easier for these drugs to actually work. You're not doing anything more exciting than that. Now, when we move over to type 2 endotype, that's a very different part of the immune system. Rather than neutrophils, we're going on to things like eosinophils, basophils, mast cells, more the allergic side, IL-4, IL-5, if you're interested in the immune system at all. These people tend to have asthma, eczema, hay fever, things like that. They get very swollen nose, boggy, sort of wet looking nose. And interestingly, a lot of these people seem to lose their sense of smell, or they feel like they can't smell very well. They get a sort of watery, sort of mucoid sort of discharge coming out of the nose rather than thick green, brown stuff. It just sort of pours out in a different way. And so these people feel very different from the type 1 types of sinusitis infection. But interestingly, what happens is that when you give these people macrolides, the clarithromycin, which is what we typically give in this country, 250 milligrams each day, it seems not to respond as well for these patients. It seems it's because I guess it's not a neutrophil thing, and we think that macrolides affect the neutrophils. But because it's a different cell altogether causing the same sort of problem, it becomes a very different disease, and macrolides don't work very well. These antibiotics don't work well for the type 2 people, people with a lot of asthma and things like that, and loss of sense of smell. What part of the treatment does work for these type 2 people is the steroid component, which is why I talked about the nasal spray, putting steroids in these things. So you fill it up with water and you pour in, so we typically pour in budesonide, uh, zero point 0.5 milligrams or up to 1 milligram of budesonide. And when you pour this in, whatever dose your doctor's given you, you need to make sure that you're eligible for all of this sort of stuff. You need to shake it really well. Put your finger over the top, otherwise it goes all over the place. You shake it really well because the budesonide doesn't sort of dissolve in the water. It sort of mixes up with it. And if you leave it on the side, it'll just collect at the bottom, and then you won't really get it up into your nose. And so you end up using the spray and this. So you really go for the steroids. And pushes up your nose and get this to go around. The idea is to try and get it around as much as possible because we think that steroid nasal sprays, which is useful, it's really hard for it to go up your nose, between your turbinates, which is why I talked about that in the anatomy bit, and into that hole, into those holes that go into your sinuses, left, right, and center. So what we're trying to do is really get as much fluid up there as possible to give your steroid the most chance of contact with the areas it needs to get to. Um, I think a nasal spray is about zero point 0.1 mil or zero point 0.2 mils of fluid that goes up your nose. This is 240 mils in this. And the idea is to sort of bathe everything in a bit of steroid and try not to just blow your nose and get it all out again. If you really want to do that, I would clean your nose out first with one of these and then do another one of these and pour in the budesonide then. Now, I'm not a great fan of budesonide. It's the one that we have the most evidence for, but I think like things like the drug in Nasonex or the drug in Flixenase, the slightly lower bioavailability steroids might be better. We just don't have the trials yet. So it's an area that I think we're moving towards a slightly safer steroid. And it's important also because although there have been trials that showed if you use this and the steroid spray at the same time to try and really get on control on top of your chronic sinusitis, we worried that perhaps we're giving too much steroid. And actually, over 3 years, I think there was a trial that showed it didn't increase your cortisol levels and it didn't suppress parts of your body with that amount of steroid. If, however, we found that you're using an inhaler for your asthma, because a lot of these people have asthma, and using a steroid spray, and you're using this bottle full of steroid, then we start seeing that it starts affecting your system. Your cortisol levels start dropping a little bit. So we need to be a little bit careful about how much steroid we're giving people. And I think the move towards the what I would call the low bioavailability steroids, the ones that don't really go around your whole system and interact with the rest of your body, it stays in the lining of your nose. That those are the drugs I think we'll be moving over to. But I mean, watch this space. I'll tell you more about it at some point. Another thing you can do in these people, even though it's not a polyp as such, although polyps, it works well for polyps as well, is to give oral steroids for a really short time, maybe 5 to 10 days, something like that, to really get on top of the swelling and the inflammation inside your nose that opens up your nose. So this spray and this irrigation can actually get round. The antibiotics can sort of really work their magic because once it's cleared out all that, flushed out all that infection with the one of these things. I keep picking this up. I'm going to say NeilMed Sinus rinse from now. But once this has flushed everything out, it can't flush it out if everything's all bunged up. So we tend to give oral steroids in some really, really bad sinusitis people just to give them a bit of respite, open everything up so some of these treatments can actually work. So we'd end up giving sprays, that NeilMed sinus rinse with budesonide in it, and also oral steroids. We tend to give 0.5 milligram per kilo. So, say if you're 100 kilos, you give 50 milligrams. So it's quite a lot. Make sure that you are aware of the risks, and there's loads of problems with taking oral steroids. Uh, you will gain a bit of weight in that week or so, but it comes off rather quickly. It's more fluid retention. It can give sort of psychological problems as well. So be careful. Make sure you take it with PPIs, something that stops from causing a gastritis and things like that. But you can look all that up and talk to your doctor about that. Now, some people out there might be thinking, look, I'm using all this stuff and it's just not working. My sinusitis, because of my allergy or this, the eosinophilic problem inside my nose is really, really bad. What can I do? I can't keep taking oral steroids just to keep on top of this problem. What can I do? And we are moving towards using more the cure for some of these allergies. So if you know what you're allergic to, say house dust mite or fungus and also molds and hay fever, all those sorts of things, and it's causing terrible problems with your sinuses, that may be a situation where you go to your allergy clinic or your sinus clinic, whatever, and say, yeah, this isn't working. What do I do? Can I not have the cure for this hay fever or not have the cure for house dust mite? Which is either we're moving away from injections, but it's either like a thing that dissolves under your tongue every day for a few years or an injection once a year. There are little treatments out there which eventually will cure your hay fever or cure your house dust mite allergy and then bring down the swelling in your nose. So you don't have to use so much steroid and things like that. there's an awful lot of stuff out there that we're moving towards. It's treatment, as I said, the thing that dissolves under your tongue, it takes 3 years. It's a little dose every day that slowly sort of sorts out the allergy problem. But you need to know what you're allergic to. So you need to do allergy testing, either the pinprick thing up your arm or what we call a RAST test, where we take a blood sample and check hundreds of different allergens you could be allergic to. Like in London, we're all allergic to London plane tree, and I'm not sure if there's a cure for that one yet. But house dust mite and all the simple things, birch and grass pollen, all that sort of stuff we can do. But that's one thing to think about if the allergy thing is really getting on top of you. I guess since I've talked about immunotherapy, I should talk about the fact that with polyps, I know I said I wouldn't talk much about polyps, but I can't help myself. With polyps, with this allergy problem, if you have um, remember I said at the start of this bit, it's IL-4, IL-5, IgE. There are immunotherapies for these three things. So there's an anti-IL-4, anti-IL-5, anti-IgE. These are really expensive new drugs that are coming out, which you can use to calm everything down and open up your nose. It seems to also help these infective episodes as well. But at the moment, most of the research is for polyps and chronic sinusitis rather than people without polyps and sinusitis. I think it's moving that way. I see a lot of trials in the really boring things that doctors look at. There are a lot of trials out there for people using these biologics, immunotherapy for anti-IL-4, anti-IL-5, IgE, and things like that. So hopefully, I'll give you some better news. But it's a really interesting thing. This has only sort of changed in the last sort of 5 years or so. But now I'm going to move on to type 3, which is quite rare, I think, in the Western world. Now, these people are slightly similar to both 1 and 2, mostly 1 because we think it's more neutrophils, so the more classic. But you get really thick, lots of discharge coming out of the nose. These people tend to be a bit more elderly. They don't really work very well with macrolides or steroids, really, but there is a bit of overlap with the other two. Um, and these are the sorts of people who end up having lots and lots of operations for some reason. And we struggle with these sorts of people. We're trying to find if there's I personally, I think there's lots of little individual problems here. Maybe even a genetic disease or genetic types that fall into this category because it seems not to be so common in the Western world. So we don't really know much about how to treat these people, but we are trying to fix these type 3 endotypes. We find because it's neutrophils that the macrolides, the antibiotics, erythromycin, azithromycin, those sorts of antibiotics seem to work a little bit better than the steroids. But to be honest, we would give them everything. We'd give them the NeilMed sinus rinse with the budesonide inside, or flixenase, or fluticasone propionate, or mometasone inside it, the sprays, anything we can to try and open up the nose and help these people avoid getting these horrible sort of infections and problems within their sinuses. It's an area that we're trying to figure out, and actually, it's only in I think it was EPOS 2020 when they for the first time said, look, nationally or internationally, I think EPOS guidelines are, uh, these are three types of people we should be talking about. So 5 years ago or 6 years ago now, we've only just started talking about the fact that there are lots of different types of chronic sinusitis. And because I'm being rather vague now, we don't know what to do in a lot of people. And these situations, you really need to have almost like a team of people around you, a medical rhinologist, an ENT rhinologist, so people who deal with the nose, an allergist, uh, geneticist, all these sorts of people in a sort of MDT multidisciplinary team. It's really hard to come by. My friend does it, Vikas Acharya. He's brilliant at this sort of science thing. I'm actually going to try and get him in and talk to us at one point because he knows about all this stuff much better than I do. And he's trying to lead a team that makes for these people who are really suffering with their sinuses. They've had lots of operations, they've tried these sorts of things. They're not able to get these blood tests, the IL-4s and the mast cells and neutrophils and cytokines and all that stuff to try and delineate exactly what's going on in their immune system in their nose. and try and figure out what's the best treatment for them to get them back on track. At the moment, a lot of times, a lot of rhinologists will say to you, look, I can make you feel better, but to cure you, at the moment, where we may not get there. We're trying to make your life much more tolerable, much more easy to tolerate in the long term. But to give you a pill and everything will go away, I think it's pretty hard for some of these people until we know more. And the good thing is that loads of people are willing to put lots of money into this sort of thing. It's not like snoring and sleep apnea where no one really cares. Um, Rhinitis or rhinosinusitis is something that people are putting a lot of money into, and research companies are really pouring stuff into it. So it's much more. They've got tons of money to spend. Loads of research papers are coming out, and yeah, it's really interesting, really changing quite a lot. And I hope this is being of some value to people out there. I appreciate it got quite heavy near the end. Um, but I kind of like the research bit. And I think personally, if you figure out exactly what the person in front of you has wrong with them internally, rather than just saying, "Oh, this is what I do for sinusitis," then you get much better outcomes. I mean, to be honest, like I said at the start, cleaning out your nose, using a decongestant, all that sort of stuff sorts out 99% of people. But there are people out there who may be watching this. I doubt you'll be watching this, but if you do get to this point, we are trying to fix it. And hopefully the last bit of this video where I talk in a bit more detail about it has been of some use to you. Anyway, uh, thanks very much. I will ask Vikas to come and talk here. I think he's free on Thursday mornings. Anyway, take care. Thank you very much. Bye-bye.